So good morning, good afternoon, good evening, ladies and gentlemen. Welcome to this special Global Leadership Series, a session being held in collaboration between SickKids Center for Global Child Health here in Toronto and the Institute for Global Health and Development at the Aga Khan University. The topic of today's series discussion is COVID-19 vaccination strategies, the reality of the global rollout. And we're absolutely thrilled to have a stellar panel of speakers who will be talking to us about this, and I'll have an opportunity to introduce them in a minute. And they represent Gavi, the Vaccine Alliance, the World Bank, and a Ministry of Health representing many of the low and middle income countries. But let me start off by an acknowledgement, given where we are, to the land on which SickKids operates here in Toronto. For thousands of years, this land has been the traditional land of the Huron-Wendat and the Puritan First Nations, the Seneca, and most recently the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. SickKids, as an institution, is committed working towards new relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land, caring for children and their families. Now, with that acknowledgement, I'd like to put some housekeeping rules in front of everybody, and that is we will have the three speakers who will finish their presentations, and then we have the Q&A, the question and answer, open to participants to put their questions in. We will select and pose those questions to our panelists and hope to have at least 2 rounds of Q&A, answering many of the questions that have already been shared with us and those that will arise as part of the discussion. So I'm absolutely thrilled to introduce our first speaker, who is Alex Beecher. And Alex has a background in chemistry and is unique in that he had a pole position in the actual design and development of the global COVAX facility at the Global Vaccine Alliance, Gavi, that everybody knows about. He's currently the executive officer to the managing director of the Office of the COVAX facilities. And he will today talk to us about the reality of developing this and talk about the vaccine challenges and solutions under the COVAX facility. Alex, the floor is yours.
Thank you very much, Dr. Bhutta, and a pleasure to be here, and nice to be with everyone as well. Very good to have a few minutes to talk a little bit about what we've done here at COVAX and some of the outstanding challenges and solutions that we face in the global rollout of vaccines. I'll try and get through it in the next 15 minutes, just a few topics. Where we start will be first by just having a brief introduction into what COVAX is. So basically, at the beginning of the pandemic last year, the global health institutions came together to try and come up with a response that would ensure that all countries had access to vaccines when they became available. And we put out at the beginning of this a handful of objectives, which are shown here. The primary one was around ending the acute phase of the pandemic by the end of this year, which would be facilitated by delivering 2 billion doses of vaccine also in this year, with the help of a very large and actively managed portfolio of vaccines. And I think critical to all of the work from the beginning was the concept that we were doing this in as fair and equitable way as possible. At the heart of the COVAX effort was this idea of trying to ensure equitable access to vaccines for all. Now, as things have played out, it's not exactly the reality on the ground, but we think we've made meaningful contributions towards this. The COVAX initiative is a partnership. It pulls together, as I already mentioned, a handful of important global health institutions to sort of span the value chain. So starting sort of upstream at research and development manufacturing, we work with our partner CEPI, the Coalition for Epidemic Preparedness Innovation, and they work with manufacturers in early stages of development to try and support their efforts, and were instrumental in the early stages of the pandemic in investing in early stage vaccine candidates. Gavi, which I represent here, handles to a large degree the procurement of these vaccines along with our partners UNICEF. We incentivize manufacturing expansion, all with the objective of developing a large and robust portfolio of vaccines to roll out to participants. UNICEF, as I already mentioned, is a core implementing partner, really critical both in the stage of getting doses to countries from manufacturers, and also critical helping get those doses into the arms of people around the world. And then finally, need to mention WHO. They've been along the ride since beginning and really play across the whole space, often in the sort of normative capacity, but also critically helping with policy, safety, regulatory, and allocation. Our part of this picture with Gavi is the COVAX facility. And so this is sort of the procurement branch of COVAX, and it sits in between this, in this schematic, as you can see, participants and manufacturers. And what it does is it pools the demand and financing from participants and also from donors to contract supply from manufacturers. And then in the same way that we pool demand, we pool supply by bringing together a portfolio of vaccine across multiple manufacturers. The structure of how we actually work with different participants is depicted here. So we opened our doors last year to any country in the world who wished to work with us to access vaccine. And they would join the COVAX facility as equal members. And those countries who were eligible for ODA financing, so low income and lower middle income countries, would be supported by donor funds. And actually to date, we've raised around $10 billion for the procurement of vaccine, with an additional $1 billion to support the delivery of vaccine. And these participants, which we refer to as the AMC 92 countries form this group of participants, are benefiting from donor-funded vaccine and delivery support. I like showing this map. This shows the world of COVAX participants. I think at latest count, we're at about 195 countries and territories around the world. In the sort of teal color are countries who are eligible to receive vaccine for free from the COVAX facility. And in red are those who are self-financing countries who are paying for vaccine through us. And I think this map nicely encapsulates how vast the global effort it is. It really touches all corners of the world. So with that sort of background on what COVAX and the COVAX facility is all about, I'm going to move into the next topic, which is where we stand on the global rollout of COVID-19 vaccines. And I mean, I think here there's some good news and some bad news. I think the good news is that if we go back in time to over a year ago at the beginning of this pandemic, I don't think anyone, even sort of the best case scenario, would imagine that as of the end of September this year, vaccination programs would have advanced as far as they have. So 43.5% of the world's population have been vaccinated with at least one dose of COVID-19 vaccine. I'm sure that number has already climbed further in the last few weeks. And over 30% of the world's population have been fully vaccinated. And back when we were originally looking at numbers and trying to come up with objectives for this year, our goal that we put out was 20% of the population to be vaccinated. And if you look at a global average, that's been achieved, through support from COVAX, but obviously also from other sources of vaccine as well. And that would cover the highest risk population. So that's good news on the aggregate level. Of course, it masks at the individual country level, very severe inequalities. This chart depicts countries in terms of their coverage, and you see a range from effectively 0% coverage at the bottom range, all the way to north of 80% coverage with a single dose of vaccine. So really quite a wide range. And what also stands out, so in blue are shown countries that are low income or lower middle income countries, and you can see very much that towards the left-hand side of this chart, or the cluster of the blue dots, and towards the right-hand side of the chart, wealthier countries clearly are well in advance of those with fewer resources. And so significant variance here. Still a handful of countries who have yet to launch even the COVID-19 program at all. And you see some other numbers on the right-hand side breaking down how many countries fall into various coverage bands, with still over 100 and with still 42 countries that have less than 10% coverage overall. If you look at the sources of supply behind vaccine programs around the world, this is a nice slide coming from our partners at UNICEF. That shows that really there's a pretty wide variance in where different groups of countries are getting supply. And you can see a trend that the wealthier countries, more resources, are able to get their supply primarily through bilateral deals with manufacturers, direct deals with manufacturers, or the regional procurement mechanism of the EU. But for low middle income countries and low income countries, in the darker gray, you can see very clearly that COVAX is a very significant portion of the supply going to those countries, and is continuing to play quite an important role for them. This is actually this view provides a bit of a further breakdown of sources of supply for different countries, and you can see that there's quite a range in terms of where lower middle income countries, low income countries are accessing supply. Some lower middle income countries do have significant sources of supply outside of COVAX, but 27 countries in the AMC group do not have supply beyond COVAX at all, and another 45 are relying upon COVAX in a pretty significant way. And so again, the global numbers mask a pretty wide variability, and for many countries, COVAX continues to be a critical source of supply. I mentioned a few of these numbers earlier. This slide summarizes where things stand in terms of some of our key metrics that we follow here at the COVAX facility. So as I already said, close to $11 billion have been raised for COVAX AMC participants. We've developed a vast portfolio. We have 11 vaccine candidates with signed agreements against an initial target of 10 candidates. We had hoped to deliver 2 billion doses in 2021. We've seen a significant erosion in that number. We're at 1.4 billion, and I can provide further detail on the next slide. We've shipped doses to 94% of COVAX participants who have received allocations. So pretty substantial number of those countries that initially signed up for support from COVAX have actually received shipments, including to Canada, actually. And then in terms of deliveries, and this is an area that continues to be a challenge for us, we've delivered, we're approaching 400 million doses. And that number creeps up every day, and it's been a bit of a slow climb over the summer, but in recent months, it's been growing quite quickly as new supply sources keep on coming online. This is a picture that shows a map that shows where we've actually sent doses. So as you can see, quite a wide set of countries here. 144 different participants have received doses from COVAX at this point. And as I already mentioned, supply has progressively come online over the course of the year. Our forecasts have eroded over time, but we continue to predict a significant ramp up over the coming months. And in some months, we're expecting nearly 300, 400 million doses a month to be going out to countries, which are very significant volumes. And actually shortly, we'll be surpassing the US as the organization or the group that's shipped the most quantity of vaccine to date, I think excluding China and India. So that provides a little bit about where we stand. I've already alluded to some of the challenge that we continue to face. I think really fall into three key buckets. The first, inequity of distribution, the second being supply disruptions, and the third on delivery risk. Inequity of distribution, I've already shown some of the data there. I don't think we need to spend more time. On supply disruptions, I think this is an interesting chart to illustrate this. So back in July, we put out a forecast that showed that by the end of this year, we would have close to 1.9 billion doses of vaccine available. And by September, that number had dropped 25%. And this chart gives a sense for what drives those reductions in supply. A big chunk of it is coming from J&J, who's one of our suppliers, as they've faced issues with some of their supply chains, most notably in the US at Emergent, well publicized. And then another big contributor here is the export restrictions in India that have blocked one of our main suppliers, the Serum Institute of India, from providing vaccine. And then we've also seen some cuts in supply from manufacturers that see delays in getting regulatory approval, namely Novavax and Clover. At the same time, we've put in place tools to help bolster that supply. And so, for example, we've secured agreements with Sinopharm and Sinovac, which have brought in additional doses, as well as established a donation program by which countries with excess supply can help support COVAX. The other thing that we've been monitoring is delivery risk, and I'm not going to spend a lot of time on this slide in detail, but we've watched pretty carefully across the portfolio of countries in COVAX to track how they're performing both against absorption of COVID-19 vaccines. So once these vaccines get into country, how do they get to arms? And I think some of the speakers that follow will touch upon this in more detail. But we track this and work with countries to help address these risks. But at the same time, we also watch how the rollout of COVID-19 vaccines and how the pandemic as a whole impacts routine immunization programs in countries, which are absolutely essential for us to maintain. And so we watch both of these and help work with countries to address them. So in my last couple of moments here, I'll just spend a few seconds talking about how we're addressing some of these challenges. So on the supply side, we're looking ahead to 2022 already. So we've already put in place a number of mitigations in terms of our portfolio to address some of the supply headwinds we face. But as we look ahead towards 2022, we continue to see a role for the COVAX facility in supporting countries to achieve their own coverage objectives towards the 70% WHO global vaccination goal. We also recognize the critical role of other sources of supply. I think we are quite aware that other sources of supply have been playing and continue to play a very critical role. In particular, the Africa Union's initiative, the African Vaccine Acquisition Trust, AVAT. And then I think the last piece we think about as we think about supply in 2022 is the need to put in place already risk mitigation and have flexibility such that if additional shocks hit the system, whether they be the widespread need for more boosters, a new variant that emerges, that the COVAX facility will be well positioned to respond and ensure that low and lower middle income countries are not left behind. We also work on inequity with the COVAX humanitarian buffer, and I'm not going to spend a lot of time here, but this is a mechanism we've set up specifically to serve humanitarian populations, so high-risk populations, humanitarian settings, and 5% of COVAX AMC-funded supply, so 5% of the doses funded by donors are available through this mechanism to serve humanitarian population. And then I think this is my last slide on the delivery risk piece. So, as I said, we've been monitoring this closely, and we put in place solutions across the value chain to address it. So on the upstream end allocation, we have been working very closely with countries to try and better understand exactly what their needs are and what they are able to take on in terms of capacity. And so we try and match better the supply in our portfolio to the needs of countries in the first place, to avoid situation where we're giving countries the wrong amount at the wrong time of the wrong type of vaccine. In-country logistics, we have an extensive program supporting the deployment of ultra cold chain and other cold chain equipment. Pfizer is a big part of our portfolio, and we've been working with countries to ensure they're ready to accept that vaccine. As we know, it carries quite significant complexities. On actually delivery, we continue to work with our partners on the ground at UNICEF and WHO to support delivery capacity expansion scale up. And then finally, looking across other big factors that affect the ability to get vaccines to arms. We work on demand generation, vaccine confidence, leadership capacity. Clearly, rolling out a big program like this requires a lot of human resources, and then finally, reporting and surveillance. And I think with that, I'll close with a few of the major asks that we have today. So, and I think important for people to understand where we can use support and continue to use support. So, one is around our goal to increase the contribution for AMC countries. Second is around continuing to put pressure on manufacturers and governments to prioritize delivery of COVAX doses. It's been a struggle for us, but we need to ensure those are prioritized to address some of these inequities. We are watching carefully on evidence gaps, because some evidence gaps we expect to emerge over time, and we need to ensure those are tackled equitably to support rollout in low and lower middle income contexts. Data information sharing is critical. There are a lot of initiatives underway, and we need to make sure we have a clear picture across all of them. We need to support delivery, and we need help on doing that. This is a big load that's coming to countries, and we'll hear more about that, I'm sure, from our other speakers. And finally, we want to make sure we do have active collaboration across the different mechanisms supporting this response. And with that, I'll wrap up. Thank you very much for having me.
Well, thank you, Alex, for that wonderful summary of a very complex process and also a successful process, if I may say. So without further ado, let's move on to our second speaker and the important topic that he will address. So Dr. Mickey Chopra is no stranger to our respective centers. He's been an invited global leadership speaker before. He's currently the global solutions lead for service delivery in the health, nutrition, and population global practice at the World Bank, where he's responsible for organization management and oversight of the quality of health services that the World Bank is engaged with. His claim to fame is that he was, until recently, before his move to the bank, the person responsible for implementation of health programs at UNICEF. He was the chief of health and the associate director of programs at UNICEF, where he saw over a fantastic tenure a lot of activities in relation to maternal newborn child health, immunization, pediatric HIV/AIDS, and health systems. He will be speaking to us today on the challenge that COVID-19 places on low and middle income countries, and particularly in the context of what we need to do to ensure that we go from readiness to scale and overcome some of those implementation challenges. Nikki, the floor is yours.
Thank you, Zulfi, for your kind words. And I just want to make sure that you can see my slides.
Yes, we can. If you would like to also.
Presentation mode, Nikki?
Yeah.
Yeah.
Yep.
Great. Thank you, everyone. And thanks again, Zulfi, for the warm welcome. As Zulfi said, Professor Butta said, I'm going to build on Alex's presentation and be a bridge to Dr. Faisal's more in-depth country examination. I'll just give you an overview of the challenges of moving from what we call readiness to implementation, and give you some insights into some of the work that we're doing, but also, financing for us is a key thing, and so what kinds of things we're looking at as we're considering the financing implications as well. So as Alex has outlined, one of the first things that we did before, even before COVAX was established, was to start to work with countries towards the beginning of the epidemic, when it was clear that vaccinations were going to be required, to do what we called a readiness assessment. So across almost 145 countries, we worked with WHO and UNICEF and other partners to do a fairly rapid assessment of, what kind of cold chain they have, what kind of health worker systems, what kind of information systems, data systems. So we looked at all the key systems that will be necessary for a vaccination program for adults, as well as for existing programs for children and girls and so forth. And based on that, we started to work on improving the readiness, including the establishment of national committees and agencies and vaccination plans, and also then the financing gaps. And that's what then informed our raising of funds. We mobilized over 4 billion just for vaccination, and that has since risen to even more. We can discuss in more detail during the Q&A how that's all broken up, but basically the readiness assessments was a key input to understanding and identifying the gaps. However, going from readiness to actual implementation is what I'm going to concentrate on this presentation. And I'll show you that, as Alex did, that actual coverage has been quite slow. And obviously a big part of that has been vaccine supply, has been a major determinant of the reason for why we haven't had as fast take-up as we would like. But there are huge implementation challenges which go beyond just the supply thing. So the main message, one main message here, is the gap between readiness to actual absorptive capacity and being able to actually do it, even when financing is made available, is an important lesson and something we need to understand more. Just to build on Alex's point that supply constraints have been a major bottleneck for coverage, particularly in low-income countries, but we are seeing a ramping up, and as Alex outlined, particularly with the easing from India, but also the fact that there's many more vaccines on the market. So we're already seeing a ramping up of supply across the world. So this will hopefully become less of a constraint moving forward. So this summarizes the logistical challenge, if you like. So on the left-hand side, you'll see the number of vaccines that were being procured and distributed and used in low middle-income countries just before the last quarter of 2019, before the COVID-19 pandemic outbreak. And you'll see that it's required, even to get to the first 20% or so, or even less in this case, a 4.5-fold increase in the volume and amount of vaccine requirements and numbers of people required. And we're seeing an even sharper increase to move to the next level in this last quarter, that there'll have to be an even bigger increase in terms of numbers of vaccines procured, stored, distributed, and used safely. So it's just sort of bringing out the huge logistical training, capacity, warehousing, etc. challenges that countries are facing as they start to vaccinate a whole new population than they've previously done. This draws further on Alex's point around the averages hiding the inequities and the big challenges. So this slide just builds up that a significant number of our low and middle income countries have less than 10% of coverage, and even though it's increasing, it's still not increasing fast enough. So there are still significant numbers of countries where utilization and coverage is still far too low. And in fact, at the present rate, and this is the big concern we have at the moment, is that this graphic just shows you, if you project out at the speed at which we're going with increases of vaccination of the adult population, how many days it will take to get to 70% of the adult population. And for a significant number of countries, about 40-odd countries, it will take more than 2 years to get to that point. So, and even that, even the countries just below that, there's significant another 30 or so countries who will still take almost a year to get to 70%. So we are very concerned about the rate of acceleration, and it's far too slow in far too many settings and countries. So this slide is a summary of the major issues that we've seen across countries. Now, as I said, Dr. Faisal, I'm sure, will be digging deeper into many of these, but I do just want to spend a few minutes then just going through in a schematic manner what have been the challenges that we're seeing. Now, obviously, there are some key supply side issues, but it's not just the lack of supplies, which is, and in fact, it's becoming less the problem of a lack of size. Much more critical now is the erratic nature of the supply system. That it's very difficult for countries to plan for vaccination if they don't know how many of each one of which type is coming through. And as you know, the different vaccines have quite different safety profiles. They're quite different needs in terms of training and needs of storage and handling and management. And so uncertainty in regards to which vaccine will be available when and at what volume, and changes to that almost on a weekly or daily basis makes planning and implementation extremely challenging. And then you do have the challenge of multiple products and suppliers. And that's something we've tried to avoid at the global level. COVAX has been a great vehicle for trying to make sure that there wasn't too much fragmentation. But even despite that, there has been a number of initiatives, regional, if not national initiatives to procure in addition to what COVAX is doing. And so that makes complexity in terms of supply issues, in terms of customs, in terms of entry, even more difficult. And then what we're seing in many settings as well is the issue of shelf life and utilization of vaccines and the returning or even the destruction of vaccines because they've gone beyond their shelf lives. And that's been a very sensitive topic and a very controversial issue in some countries. There's a lot been made about the demand side, and Dr. Faisal, I'm sure, will cover this in more detail. And there's no doubt that that has played a role. But our experience thus far, and it'd be interesting to hear from Alex and Dr. Faison and others on this meeting. Our experience has been rather that this has been a relative, for many low middle income countries, this so far hasn't been a major constraint. That when the supply has been there and been administered in a professional manner, those supplies have been taken up, and in fact we just saw today from India that they've administered their billionth dose there. So thus far in the low middle income countries, there has been a lot of media attention paid to the demand side aspects, but when the system is working and the supplies are getting to communities and the vaccines being made available, uptake has been very good, mostly. So then we do get to the deployment challenges on the right-hand side. Now, one thing we were worried about at the beginning was the actual infrastructure in terms of cold chain, in terms of fridges, and as you know, the storage requirements are quite different from what we've had for previous for the routine immunization programs. But actually, this is something which Gavi and the partners have been very active on and invested and helped countries invest in the cold chain. And so what we found more to be a challenge has been more the software side of it, if you like, which is the planning and the understanding and following the vaccines and getting the vaccines from point A to point B to point C in a timely manner. And so the logistics side of it has been a big challenge of moving the vaccines to the right place at the right time. So what we found in many settings has been that they've been clogged up either at the airport or in the central or in the hospital, and distribution logistics has been a critical challenge. And that has been complicated by the fact that you do need the cold chain monitoring, you need the training of health workers, etc., to be aligned with your distribution plans. And then also early learnings and challenges with regards to mass sites versus routine and smaller sites. Quite often at the beginning, we had a lot of hope for mass vaccination sites, but we also found a huge risk there of wastage and inefficiency, for which we can dig deeper. Maybe Dr. Faison will touch upon this, but really understanding the pros and cons and the needs and the right timing for mass versus routine or through the regular system versus even more outreach type of activities. And then finally, there has been a challenge around funding. We have, like I said, made substantial resources financing available for vaccination. About 60% of that to 70% has been taken to purchase the vaccine, but it still leaves 30 to 40% for operational costs. But what we found is that a lot of those operational costs have been taken to purchase infrastructure, so fridges, as well as others. And the actual operational costs in terms of extra salaries, in terms of outreach costs, petrol, gasoline, those have been the things which have not, the financial, because of the pre-existing financial challenges, financial flow challenges in countries, has been a sticking point. And too often it's been, there's been lumpiness, that the financing flows and availability of financing at the operational level hasn't aligned with when they'd actually need the surge capacity. And so it's been this challenge, a pre-existing challenge, if you like, of donor funding and external funding marrying with internal national level operational financing, and the financial flows being too sticky and not timely enough. Finally, I just want to give you something that we're working as it's interesting to see that COVAX and Alex was mentioning, but we're also working on a way of monitoring which countries are having absorptive capacities, which countries do we need to lean in a little bit more. This slide just gives you some sort of insights in some of the methodological thinking that we're trying to do, to develop a sort of index and a nuanced index of both which countries are high risk and low risk, much along the lines that Alex presented, but also trying to break it up along to which, is it a financing flow issue? Is it a supply side issue? Is it a demand side issue? And so forth. So the challenge here is to try and develop an index which is has data which is standardized or fairly standardized across all countries, so that we can do comparisons and identify which ones are struggling the most and which areas are coming through. It is a very quickly changing field, almost on a daily basis. Yeah, so I think it's, looking at availability of health workers, what are the measures, is there standards, are there minimum levels that we need to identify, storage capacity, cold chain capacity. In particular, what we're seeing is that countries do have storage capacity, but it's often in the urban settings and the large hospital settings and not distributed out sufficiently. And like I said, the massive increase in volumes and where is that volume capacity available. So we are looking at many different components and measures of absorptive capacity and implementation capacity, and starting to paint a more detailed and granular picture of different countries and where they're at, and hopefully that'll be ready for sharing in the near future as well. So Zulfi, I'll stop there and hopefully give them some food for thought.
Well, thank you very much, Mickey, for that insightful view of how your group is approaching this and creating capacity in the country. And now we would like to move to an extremely important topic of how countries are actually responding. And we are thrilled that Dr. Faisal Sultan, who's the Special Assistant to the Prime Minister of Pakistan on Health and a Federal Minister in the Ministry of National Health Services Regulation and Coordination, is here with us. He is an infectious disease specialist, and even prior to his appointment to this important position, was the focal point appointed by the Prime Minister to help the National Command and Operations Center in Pakistan design its COVID-19 response strategy. He has a wide range of international and national oversight functions as a member of several advisory committees, and he's been at part of the core group looking at national accreditation standards of hospitals, and I know that he has his hands full, but he's been devoting time and attention to the COVID response and has led it from the front. And today he's going to share with us his thoughts on how, for a country like his or mine, the COVID vaccination challenges were overcome and the implementation accelerated. So Faisal, the floor is yours.
Thank you very much. First of all, thank you. And thank you, Dr. Bhutta, for this extremely kind introduction. I will, of course, quickly run through what I have to tell you, and we can come back to things in the QA session if required. So challenges and implementation. I'm going to talk about the fundamental organization framework that we had to put together to do this. The procurement challenges, some of which have been touched on already. The prep for deploying this kind of vaccination in a developing country where essentially, other than one exception, we had never had an adult vaccine being deployed across the population. The deployment itself, what kind of monitoring is being done and has been done, and of course, some challenges and some lessons. So the org framework was very important because we've got 4 provinces, 2 other federating units in the capital territory. And so a large country of 225 million people with a very devolved health structure. And by design and evolution, it's actually gotten devolved even more. So therefore, to claw back some of the coordinating capability required, that we formed what Dr. Bhutta has referred to as the NCOC. So sort of a coordinating framework mechanism to ensure that everybody was on the same page. That entity has met every single day since the start of the pandemic, and only relatively recently have we taken weekends off. So it's been a very active and hands-on engagement. It was required essentially to coordinate, but also to bring some force of law to ensure that we were all on the same page, to form a ministerial committee, which included a bunch of important and key governmental functionaries. And of note, other than the four listed, we actually had to bring in the Drug Regulatory Authority into the ambit, simply because in the past, as far as vaccines, biologics, and pharmaceuticals are concerned, by and large, we've depended on proxy approvals based on things that were manufactured abroad. But for vaccines and biologics, this was going to be a first time that we might have had something domestic, and so it was very important to line that duck up as well, because we foresaw what was coming. We created a technical committee of experts to really sift through what at one time were over 150 candidates, small, big, promising and not so promising. And they, this group, experts included very capable people, committed people who contributed time, and really also actively contributed to discussions on access to COVID-19 tools. The other structural thing that we had to bring in was this cabinet committee with 3 full cabinet ministers to ensure that we were making or could make purchase decisions, primarily because, as I'll mention, this kind of large procurement, some of it was opaque, had to have protection. Otherwise, government servants were skittish and jittery about signing orders that could get them into trouble later on. And lastly, the National Disaster Management Authority had been useful in the other phases of the pandemic, including procuring PPEs and so on. But at this point, we also felt that they would have the necessary authority as well as immunity from this kind of emergency purchases being looked at for intentions and probity. So the broad strategy that was put through was self-evident. I think everybody can see it. We, of course, required an adequate supply, but then the ability to deploy, and then, of course, to ensure that there was demand. I think all of us across the globe have been surprised, perhaps on both ends of the spectrum, on how demand has played out and at different stages of the pandemic. I used to joke in the beginning that we would have really an initial coalition of the willing, words borrowed, of course, of those people that were willing and able and were keen and ready to get vaccinated. But then things would really slow down quickly. Our experience so far has been that it has slowed down much slower than we thought it would. So a little bit more specific data later on. And as far as the vaccine or the vaccination drivers are concerned, of course, voluntary I've mentioned, but some incentives and obligations that we've put together to ensure that it becomes obligatory in many congregatory activities to ensure that you're vaccinated, including travel, tourism, the education sector, and transports, and on the motorways and some businesses, etc. So the first challenge, of course, was supply and availability. And so we initially felt that our first deployment would be through COVAX, but it was not to be, and we'll talk a little bit about that. But so we ended up starting with donations from China, and the first 500,000 came through in February. And as amounts in similar sort of tranches have come through later on as well. So far, we've had 4.7 million doses from China as donation. The other thing that helped us to ensure supply and availability was to actually bring in one vaccine that was to be formulated, filled, and finished in Pakistan to add up to the menu of options that we were going to have. So this was sort of a first for us at this time. And because it was done in really real time, I think a fair bit of credit goes to the NIH in Pakistan that were able to sort of do this literally as the pandemic broke. Then, of course, COVAX, we engaged with them very early on, and we had some early disappointment, as I mentioned, and some of it was, unpredictable for us. So we had to switch around the sequence in which we would procure vaccines. So, and again, so far we've had 27 or nearly 28 million doses from COVAX so far. So nearly 5 million from China, another, say, about 30 million odd, just short of that, from COVAX. And we've purchased about 103.5 million doses so far. So to date, 136 million doses. On the right panel, I've actually put out the other challenge in this. Because we are a large country, and we realized very early on that if we are going to vaccinate any sizable proportion of our population, we are bound to need a bunch of different sources. So the first three, Sinopharm, Sinovac, and CanSino, are Chinese options. CanSino is a single dose option, and that's the one that we were doing and are doing the fill and finish it. And that's called ParkVac. Then a relatively small deployment of Sputnik, AstraZeneca, Pfizer, Moderna. And this, ice cream flavor list of vaccines has created some important logistic challenges for us as well. I'll talk about that. The other thing, of course, that we had to do was get the delivery system prepared. Now, as I mentioned, our system primarily has been focused on childhood vaccination. And even there, we've, of course, struggled to get the proportion of children who are vaccinated higher. And we've had some success on it recently. And interestingly, I think that some of the investments in the relative recent past actually paid out in a very big way here. But before we actually got down to the actual reception, storage, and distribution of the vaccines, one thing that we were able to do was build this national immunization management system. This leverages heavily on the national digital identity database. I think this investment into this has really paid out very well in this entire pandemic, including testing and so forth, but especially so for the rollout of the vaccines. So every single vaccine that is given in Pakistan is actually tagged to your digital identity. And so therefore is trackable and identifiable by individuals, and has really helped us to look at things like breakthrough rates and things that really are available at the click of a button to analyze beyond just the deployment and some other analyses that are helpful. Then, of course, we had to make sure that we were ready to receive and keep cold the vaccines that came, and of course, ultra cold. There was some investment made into getting capabilities for freezers across the country to ensure that we could use, if at that time we thought if Pfizer arrived or other vaccines with a colder requirement arrived. And so that was put in place, and it's actually served us in great stead. And then, of course, the coordination in supply chain management. When you have 6 or 7 different vaccines, each with a different set of requirements, different time intervals, and so on. So this has really been a challenge. When you're trying to supply a system and make sure that you don't have stockouts across over 5,000 to 6,000 individual places and units, mobile units that are receiving the vaccine, to ensure everybody's supplied well and the pipes remain full and don't dry out even in the far reaches of the distribution, have been really a challenge. And of course, the issue of managing supply from our purchasing as well as through COVAX, and to make sure that the provinces all receive an equitable supply as per their populations and needs. I will not dwell on the tracking and monitoring immunization. The idea is to just tell you that very detailed system, not just for administering or deployment of the vaccine, but also for the adverse effect monitoring system that was also put together through this NIMS. So we rolled out like most countries did. We started out with frontline healthcare workers, and then healthcare workers and those over the age of 60, and really started from the top down, and the 80 years old plus started receiving SMSs first, and we eventually have ramped up, and the present state is that we've got 12-year-olds currently, 12 and over currently eligible to receive vaccines. I'll just put this panel up just to tell you that a lot of detailed monitoring, I've just put up a few, but extremely detailed monitoring had to be done at the NCOC of both arrivals, usage, bottlenecks, how good we were at second doses, and a million other variables and numbers that are actually crunched and evaluated every single day. So where we are today is, we started out relatively slow. It took us 113 days to get to our first 10 million doses, but it's sort of, sped up fairly nicely since then. And our peak day, the top day was toward the end of August, and we had 31st of August it was, and 1.5 million doses in a single day. It slowed down a little bit since, but we're trying to use some levers to jack it up again to what we think is a very reasonable number, would be between 1.5 million to 2 million doses a day. Now, this is a snapshot. I've just put it out today. Of course, nobody's going to be quizzed on the numbers, but it is to give you an idea that how we watch it on a single daily basis. This figure on the right, the 98.5 million, is the doses as of last evening. So we should be hitting the 100 millionth dose in the next 3-4 days. And there's a whole detailed analysis of how it's being monitored and tracked across all federating entities, as well as by vaccine types, and how many people got the first dose and second. So you can see that a fair bit of detail is looked at the central level every single day. On the proportion of vaccine population that is vaccinated, so this has been a moving target for us in the sense that we started out with the total population, of course, but we also saw what was the eligible population as far as our criteria was concerned. So the current definition of the eligible, of course, is the 12 plus. And so at the present time, of the fully vaccinated people are 24% out of the eligible population and 16% out of the total population. But 44% of the population has at least received one jab. So if you look at the total, 16%, these are fully vaccinated. And if you look at the eligible population, which is kids over the age of, people over the age of 12, that is 24%. We also tried to dig down and focus on 25 key districts to see how we could set targets. So for example, we've set targets for the 31st of October, and which is only 10 days away. And of course, we have a full range of performers. Islamabad, Capital Territory, understandably 65%. There are other cities and places which are in similar ranges, but then we have ones that are trailing as well. So a lot of extra effort is being put into place to ensure that these averages, as we all know, don't hide out the outliers. So our targets are, of course, to have 70 million people vaccinated by December, and at least, and the partials would, if you count the partials, that would be 100 million people. We've got monthly targets. So far, we've got reasonable availability of vaccines, and I think we are okay between our purchased vaccines, those coming through Gavi, and so on. So what have been the challenges? I'll quickly run through them. Of course, first and foremost was ensuring availability, but not just availability at the outset, but to manage this really complex supply chain of multiple vaccines, and to make sure that we don't run out of one or the other, because we just did not want to be doing mix and match at this point. Second doses, especially for things like Sputnik, which of course has a unique configuration. The first and second doses are different, has of course presented yet another challenge. Financing in Pakistan, of course, has been a challenge, but so far we've put out money where it was required from the government exchequer, and wherever we were able to finance this from, for example, the Asian Development Bank or the World Bank, we've utilized those facilities as well. One of the important challenges that I touched on was buying in a public procurement environment, especially when the sellers for us in many circumstances wanted NDAs. And at that point, many manufacturers were just not willing to supply unless you did that, because of course, for their own marketing and reasons of differential pricing that they must be doing for other places. So that was a very important challenge, because civil servants being always worried on what they will be asked about later on for decisions that were done in an emergency environment were worried. So we had to really address this through the cabinet committee and also moving purchasing through the NDMA that are somewhat protected from this kind of situation. The HR training was very important because we were switching from really childhood vaccination to adults, but I think that's gone on quite well generally. The communication challenge continues to be an issue. Every single day, we have somebody or the other. And as we go further and further in the epidemic, you discover more and more experts into pseudo experts coming online and propounding various theories. So we've had to constantly try to stay ahead in this game. We've been helped really by the Ministry of Information, by social media interventions, as well as by the inter-services public relations. So we've got a number of tools that have helped us to address fake news, but it's a daily challenge. As we get past cities as we get past large cities, the outreach into more rural areas is a challenge because we have places like Balochistan, a large province, but with a small population. So to reach out populations that are spread out in very difficult terrain is quite a challenge. Things have not been made easy by vaccine preference by a bunch of countries. Everybody wanted their own flavor. And so this created trouble for us in situations where Pakistanis needed to travel for business, for education, or for employment, or any other reasons. And therefore, we've had to allow a very small number really out of these hundreds of millions of doses, less than 100,000 doses, but we've had to allow individual citizens to have administrative extra doses to fulfill requirements of travel to countries that they have to visit. This is the only category for which we actually charge a small, just the cost essentially of the vaccine. And all through this, the other challenge, of course, has been to deal with other public health needs, including the polio campaign, which is going great, but we need to make sure that we don't lose our advantage there and we get rid of polio once and for all. And of course, currently the northern part of the country, Punjab and Islamabad, have a dengue outbreak as well. So the balloon stretches only so far. So it does, whenever there are these campaigns and challenges, some of our vaccine deployment slows down, and we've seen this very recently. We're trying to push that back up. So that's essentially where I'll stop. I'm again thankful to all of you for listening patiently and for being invited here to speak. Thank you.
Thank you very much, Dr. Faisal, for that wonderful insight. And this leaves us in a happy position with about half an hour for discussion. I'm sure there are a ton of questions, and I've already received a few. But why don't I start with a question for Alex, which has been asked before and has been directly asked of you by Dr. Mukhi from our University of Health Sciences. And the question pertains to the endorsement or delay in endorsing some of the earlier vaccines that became available out of China by COVAX. And I see that they are now in the list of vaccines. But did that delay perhaps limit COVAX in terms of its choice of vaccines and has now resulted in all of this backlog with the one preferred supplier disappearing?
Thank you, Dr. Butta, and thank you also to Dr. Zoltan and Dr. Chopra, very interesting presentations. So maybe first to take the question around the delayed endorsement. So one of the strengths of the COVAX initiative is the fact that it's a partnership. And so we work very closely with WHO on matters of regulatory as well as policy issues. And this question around the Chinese vaccine, at least in the early stage, was really a regulatory question. Those vaccines were treated through the standard WHO emergency use listing process and were granted an emergency use listing once the data had met the bar. And so those conversations started on the same timelines as any other candidate, but it was only until we received sufficient data that we were willing to grant, or WHO was willing to grant the emergency use listing. And so, you know, on the one hand, it was slower than some of the other products. On the other, it was important to maintain a consistent quality in terms of evaluation. And I think in the long run, it is critical for maintaining confidence. And so that's how I would address that question. But the next point is how it relates to the portfolio. And I think a few aspects there. So, you know, from the beginning, we always at COVAX believed that a diverse portfolio was critical. And Dr. Zoltan as well, I think, embraced the same strategy as well in Pakistan. We couldn't put all our eggs in one basket. We did make a big bet in India. I think it was hard to see how we could reach and achieve the volumes we were looking to procure without having a significant source of supply coming from India. But we always were seeking other sources of supply. And indeed, the Chinese vaccines did enter the portfolio later, but that was, the timing was related to some of these questions around the regulatory acceptability. And so potentially you could have engaged a bit earlier there, but I think we were able to move quite quickly as the situation in India unfolded and as the data on the Chinese vaccines became clearer, and those vaccines really started rolling out to countries through COVAX in I think July, August this year. So hopefully that helps address some of the questions.
Well, thank you very much. Let's move on, and Nikki, a question has been posed by several participants relating to the cold chain. And to what extent are, number one, cold chain investments proceeding as part of the COVID vaccination strategy? And is some of that unnecessary? For example, at an early stage of the pandemic, there was a lot of emphasis on the ultra-low cold chain. But as time has gone on, we've begun to discern that that may not be necessary for a range of the vaccines, including Pfizer. So should countries be wasting money on creating a cold chain that's unnecessary? And what can they do to create investments that may also help with routine immunizations?
Yes. So one of the sort of positive spin or side effects of this whole initiative around cold chain has actually been an opportunity to work with our energy colleagues, and in particular to use this as an opportunity to kickstart financing and conversation in countries around not just the purchase of fridges, but more importantly, the conversation around the green investments. And so the energy, we've been collaborating with our energy colleagues in many countries to really look at solar powered cold chain. And as you know, one of the challenges in many countries is to get the market big enough to get the prices to come down for many of these products, such as solar panels and so forth. And so one sort of positive part of this has been that because the investment and the increase in capacity, regardless of whether it's extreme cold chain or not, as you saw, the volume increases do require an investment in the cold chain, regardless of whether it's for the very cold chain aspect. So that increase in capacity has also then, in many settings, allowed us to also have a conversation with the ministries of finance and energy about electrification, and in particular the upgrading, particularly around health facilities, of solar and more sustainable energy sources. So I would argue, Zulfi, that you may well be right, that there may be some redundancy and maybe some but I mean, I don't think it's been just because of the timing and the delays that it's been a huge overspend. But I do think it's becoming quite clear that the increased capacity and volume capacity and will be required not just as a once-off vaccine initiative for COVID, but it will be something we'll have to be an endemic. It's becoming quite clear it's an endemic problem now. And so I think this investment, if it's also done smartly with the green aspect to it as well, could have positive spin-offs for both routine immunization, which will now probably include endemic COVID vaccination, as well as kickstarting a broader transformation of the economy.
And while we are on procurement, maybe I can just ask you very quickly. I was intrigued by one of your comments on the procurements, particularly for some of the equipment, etc., having outstripped the HR needs on the ground and investments. So I know from personal experience that the moment you put money on the table, sometimes people will invest in vehicles much more before they invest in personnel. So how is the bank dealing with this?
Yeah, so you touch upon a really critical issue, which Dr. Faisal also highlighted, which is that it's the operational financing part, which has been really problematic. And so, you know, we've been quite clear from the very beginning that the World Bank financing has been available even before the vaccine additional financing came in. So they, with their existing World Bank project money, whether it's in health or even outside of health, we do have a mechanism, emergency mechanism, which they could have accessed our financing to support vaccination. And many countries have done that, but still struggle to get the operational aspect. And that's been because the flow of money to the front lines has been problematic. So it's much easier to procure something in the capital city and buy vehicles and fridges and infrastructure. But it's much more challenging to get that money to pay for, you know, supplements, to pay for volunteers and outreach activities. And that's where the stickiness and the bottlenecks of financial flows has really come to the fore. And that's the reason why a lot of the money has been spent on buying things as opposed to operational costs.
Yeah, sadly so. So, Dr. Faisal Sultan, I mean, you've triggered a number of questions from our audience, and I'd like to combine a couple into maybe one single reflection from you. So, with the interest that is now emerging on not only the use of boosters, but also vaccinating age groups that were initially not targets, particularly children, and Pakistan has had a particularly challenging experience with keeping schools open or reopening schools fully. Would you like to reflect on how did Pakistan come up with a decision process around this, which has been such a thorny, divisive issue even in the West?
Right. So the initial phase of the decision making was easy in that the priority groups, if you will, were well identified. And related more to protection of the individual. Of course, it also added protection to the community. But at those numbers and in those kind of risk groups, which included the elderly, the healthcare workers, and those that were vulnerable, it was an easy decision. Beyond that, just coming down the age groups also made sense because all the available data also served the same primary purpose, which was protection of the individual. As we've come down the age groups, what's been thorny is to actually see where we really put a stop. The real issue and what forced our decision in hand was two factors. One, availability of Pfizer, on which we had reasonable data for younger people for safety, and the very difficult issue of closing and opening schools. The damage to the education sector has been tremendous. Although we kept closing and opening and tried, I think, in vain to have the majority of school children learn remotely, we came to the conclusion that if we were to open the school and educational sector consistently, we would have to at least achieve some degree of group protection in young people. And therefore, that's the fundamentals of how this decision was brought about. We have some pushback on this. And many people, of course, are sort of conscientious objectors or scientific objectors to this. And I've had to engage even at an individual level with those people who are, educated in science and perhaps, analyze and overanalyze at times. I wonder the information available, but it's been a tough one. And I really do think that fundamentally, as we've gone down the ages, it's more a public health decision rather than protection for the individual themselves. But given how our societal structure is, multi-generational families living in one home, and the risks to the older population, etc. I think all of these are what made the decision. But I think time will tell whether this really helped or not.
Thank you. Thank you very much. Alex, one question that has been asked in the audience today and has also been the subject of something in the New York Times just the last 24, 48 hours is the influence that many of these large groups, notably Pfizer's been the firing line, had with pandemic pricing. In other words, how much did these large multinationals hold a gun to the head of agencies in terms of price determination, and also in the negotiations that they had with many countries around price gouging, so to say, and the secrecy around it. So to what extent could COVAX help alleviate some of that, notwithstanding the fact that we needed to take decisions at a particular point in time?
A delicate topic. To be careful what I say on this one. I mean, I think a few thoughts come to mind. One, I think, is if anything, I actually suspect the direction of travel on prices could be up and not down with time. It's in some parts for some parts of the world. So I think a number of companies made commitments during the acute phase of the pandemic to limit profits, and I think some of them have stuck by those commitments, but it's unclear what will happen later. And this is where I think, you know, an organization like Gavi has an important role to play, because this is traditionally something we've done is focused on maintaining healthy markets, and particularly for low and lower middle income countries. So that's one way to look at it. You know, I think COVAX as a whole, my perspective is that we have done a good job of securing competitive prices, but indeed there is secrecy, and there are manufacturers who are making giant revenues and profits at this moment. And one of the things that we had in our favor was we are pooling a lot of demand and financing, so we can really exert influence at the negotiating table. Going forward, I think we would imagine this transitioning to a more standard public procurement process, whereby you would have tenders and you would have prices and transparency, and managing that transition is going to be important. It's one of the things we're currently working on. Okay,
all right. Mickey, one question that has arisen time and again is around the whole issue of COVID epidemiology, information, and also response in conflict-affected countries or countries that may be behind the Iron Curtain still. So there's a question raised on how accurate is the data out of Russia, especially given what they're encountering right now. But let me turn this around first to ask you, if you look at the global evidence on case numbers, deaths, and response, it looks as if conflict-affected countries are somehow the other spared COVID-19 because the rates are just so low. And my question is, how is this being addressed and adjusted in a global response?
Yeah, good question. I mean, as you know, I work a lot in Afghanistan, and where we have got quite a large investment in supporting the country before the recent change in administration there on COVID during the conflict setting. And it's another example. I mean, and we, you know, that was a country where we have had very good hospital data, where you know, and definitely in places like Kabul and Kandahar and places where, you know, we have a pretty good sense of most deaths are being recorded, but we didn't see a huge, you know, massive overwhelming of the system or substantial increases. So there is this anomaly in many settings where no doubt there is underreporting, but it doesn't seem to have reached the levels that we saw in South America or North America or Europe. Others here may have other experiences more than I have, and may contradict that. But from our colleague, you know, our country directors in most of these countries, they, you know, there is some murmuring, if you like, of why is this the right use of scarce development resources to be lending for vaccines when they're not really seeing huge numbers of deaths or morbidity in these very low income settings so far. So yeah, it is something which I know there are many theories, and many people on the call will be more better positioned than I am to speculate. But without generalizing too much, it has been our experience in these very low income settings and fragile settings, even with the constraints of information systems and data, where we have had surveillance sites and where we do have examples of pretty good monitoring. We've not seen a huge uptick in excess mortality.
Thank you. Well, this is a great segue for me to turn to a question that I have posed Dr. Sultan in the recent past also. So one of the hallmarks of the work that you did with the NCOC in Pakistan was the establishment of pretty innovative information systems and robust systems that built on existing community surveillance, for example, the polio surveillance program. And I'd like you to say a word or two about that. But tell me, with the information that you have, and even though it may not capture everything, but how do you reconcile global modeling data that place, for example, overall mortality rates for COVID in a country like Pakistan, and not even 2 or 3 folds, but almost 150 folds higher than what the official reporting is? What is the truth? Even if it lies somewhere in between, in some of those societies, as Mickey was alluding to, like Afghanistan, it's impossible to hide deaths. So if there were large-scale deaths of the kind that we witnessed recently in India, for example, you know, there's just no way you can hide them from the prying eyes of the media or the civic society. So Faisal, could you say a word or two about information systems, and particularly how do they relate to the information that we are getting on vaccinations?
Right. So I think there is almost a surprise or a disbelief, I would say, at times on the low deaths or the low proportionate deaths in many of these countries. So let's start at the very first, at the very beginning, and dovetail from what you've said, which is death is generally very difficult to hide, and deaths of any large scale of number are impossible to hide in countries with 50 news channels all hounding for the latest breaking news of one kind or the other. So that's the fundamental context, but let's go deeper a little bit into this. First and foremost, the fact that we were able to put together an information system that flowed from over 5,000, and this is a figure to remember, over 5,000 individual healthcare provision entities all across the country, which is being captured through provincial systems and then escalated up all the way into the NCOC. And so we have a very clear idea of how many people are on critical care today, how many people are on high flow oxygen, how many people are on low flow oxygen, how many people are admitted but don't require oxygen and perhaps are in because people felt that they may escalate. Then a complete insight into how the oxygen was being utilized. So we actually looked at it from yet another periscope, which was the industry periscope. And so if people are, going quietly to some place and getting oxygen, and so that's not being reported to us. Okay, so that's the hypothesis. But the fact is, if you can't breathe, nothing else matters. And again, this is borrowed from the American Chest Society. But the fact is that this is a disease, the clinical manifestation of which is so dramatic that it is impossible to sort of hide its detection. And once in the detection system, there were very robust methods, and they still exist, to ensure that any deaths that were ascribable to COVID would get reported. Now, how does one explain the lower numbers? First of all, just the population pyramid. We did a very simple analysis, and we feel that had our population pyramid looked like, say, of a European country, for example, Spain or Italy, we would have had about 3.5 times the deaths. So let's say we've had 30,000, just I'm rounding off numbers. So we would have probably had 100,000 deaths had we had that kind of population pyramid. But that still does not explain, yet another exponent of what would be if we just extrapolated to other countries. I think it has to do with a number of different things. One is that these the response that was created, or the robust response that was created, ensured that our flexor arm, our response was nuanced, targeted, driven by where the problem was, and immense central analysis and immense reach out to ensure that we were able to actually ensure lockdowns, smart lockdowns, contact tracing. For a country like Pakistan that has not had a robust public health infrastructure, to be contact tracing between 8 and 15 contacts per index case is surprising to me, even who's been part of this story. The other thing I think that is a very important explanation is that a fair bit of our country is rural, about 70% or 65%, depending on how you define. And the social networks there are less dense. The mobility there is less dense. So I think some of that explanation comes from there. And I always keep saying the great unknown unknowns. Who knows? There may be questions, there may be answers that may be forthcoming a year from now or many months from now that might explain it.
Thank you, Faisal. I mean, and there's obviously the fact that even in urban slums, be those in India or Pakistan, the case rates and the fatality rates have been far, far less. And it's virtually impossible to hide anything untowards in those populations because they have such dense social networks. So this is something that we would be exploring, and we did explore as part of our regional comparison more recently. Now we've got just a few minutes left, 2 minutes, and maybe I could ask 30-second response from each one of you. What are the lessons from the current pandemic that you think are germane to the next pandemic? How should countries prepare structurally for the next potential pandemic? Faisal, start with you.
30 seconds. Invest in methods and systems for data flow and analysis. I think once you do that, it serves as an omnibus for responses later on. It's doable, the technology is available. We've all been remiss in not doing it in time.
Fabulous. Mickey.
Yeah, that your pre-existing health systems shortcomings amplified 100-fold. So you're only as strong as your weakest system. And like I said, for example, the PFM systems, the financial flow systems, have found to be a critical bottleneck, and one which we haven't paid enough attention to. So your pre-existing weaknesses get amplified.
So we're investing in expecting the unexpected with the depth in the system. Absolutely. Alex, from a Gavi perspective?
Yeah, so maybe I'll take it from a more global perspective as opposed to country level. I think for me, the two that stick out are on financing and supply chain. On the financing side, we were caught without any funds to begin with, and we had to start from zero. And that's a guaranteed way to make sure that you're going to be behind others who have funds at their disposal. So that's number one. And on the supply side, I think one thing this pandemic has taught us is even with a diverse portfolio, you have to have ways to protect yourself. And something that we need to be working on now is how to ensure a supply chain that can serve the world's needs next time around.
Absolutely. And that means development of vaccine capacity in parts of the world that have traditionally been thought to not need it because they could always buy it or import it. But I think this pandemic has absolutely taught us we need to have that diversified as a supply chain. Also, that capacity is not just vaccine production, there's also around diagnostics, biologicals. We need the world to be much more prepared in many geographies, including LMICs, for responding to the next pandemic. We are at time, ladies and gentlemen, and this has been a fantastic session and absolutely a powerhouse of learning. We have explored some of the difficult issues around COVID-19, but suffice it to say, there have been lessons out of this global experience. And the economic costs of going through this for the world cannot be understated. And this is really an important point for all of us to remember, that what the world has lost in all of this is well worth the investments that we put in place to be prepared for the next pandemic. It gives me enormous gratitude to our panelists for having been part of this session. And thank you very much for your attendance from near and far. God bless and stay safe. Thank you.
Thank you.
Thanks.